Good afternoon, good day everybody. My name, as you heard, is Dr. Michael Angastiniotis. I am a pediatrician and I have been involved with the Thalassaemia control program since the beginning in the early 1970s. A word about Cyprus. Cyprus is a small island. It's situated in the eastern Mediterranean and it has about 1 million inhabitants. So it's very different from India. It's a very small population living on a small island. It has been, if you like, a focus point for thalassemia, even from very ancient times. We have found evidence that thalassemia existed in Cyprus almost 10,000 years ago, from skeletons which were found in Neolithic settlements. Now, as you know, thalassemia was first described as a clinical entity in 1925 by Dr. Cooley and Dr. Lee in the United States. And he recognized it first in Italian and Greek patients living in the United States. In Cyprus, again, it was first recognized by Dr. Alan Fordry, who was a medical officer at the time, and since then it has been studied by various authors from the 1960s onwards. As I said, Dr. Fordry was the first medical officer to describe this condition in Cyprus. He published it in the Lancet very many years ago. But it takes time for people to understand the significance of a hereditary disease, especially in societies where other medical problems exist. For example, when children die of diarrheal disease, when children die of malnutrition, it's difficult to understand that very often the child dying, even though he's dying from diarrhea, may have another underlying condition making him weaker. By the early 1960s, certainly the medical authorities and the pediatricians of Cyprus recognized that thalassemia is a major health problem in Cyprus. Very little was known at that time about the pathology, about the natural history of the disease, and whether we can prevent it. And because we knew so little, in 1971, the government sought support from the WHO. And WHO sent a consultant to Cyprus. Now, the consultant, Professor George Stamateganopoulos, who now lives in Seattle, Washington, USA, was a geneticist who actually tried in the past, in the 1960s, to prevent this hereditary disease by explaining to people that if two carriers, healthy carriers, marry each other, they will have a chance of having a sick child. This was a message that was given to a population relatively ignorant of the disease, and therefore, even though he identified the carriers, they continued marrying each other and they continued having children. So it was necessary to plan services. And Dr. Stamateganopoulos' recommendation was that we should establish a national plan based on his recommendations. And this national plan was approved in 1970. Why was or is thalassemia so significant in the island of Cyprus? First of all, it's the very high carrier rate. As I said, it's a hereditary disease. The carriers of this hereditary disease are healthy in themselves. They do not know that they carry the disease, that they are healthy, that they are carriers, unless they go through laboratory tests. Now, in Cyprus, we found that 1 in every 7 of the population is a carrier. This means that every 1 in 49 couples that are going to be married can both be carriers, in which case they are a couple at risk of having a sick child. And indeed, without any prevention, 1 in 196, let's say 1 in 200 of newborns would be expected to be a homozygote, in other words, a sufferer of this lethal condition. And in the small population of Cyprus, this means about 50 to 70 babies, new babies born each year. Already we had about 600 patients at that time, approximately, which means that with the population of that time, 1 in every 1,000 of our population is actually a sufferer. Now, similar high frequency occurs in the Maldives Islands. The issue here is that very few populations have such a high prevalence of this disease. That's why we started early. That's why we were sensitized early. In India, the carrier rate is quite high, but not as high as this, of course, except in some tribal communities. Now, in addition to beta-thalassemia, we also have alpha-thalassemia, and which is a much more benign condition, and about 20% of our population carry alpha-thalassemia. A small proportion of our population, 1 in 500, carry the sickle cell gene. Of course, this is much more frequent in India, especially in central India. So, what were the recommendations of Professor Stamateganopoulos at that time? First of all, he recommended that we have or develop a program for effective prevention in order to limit the number of new affected births each year. The reasons for prevention, I will go to in a minute. We need to have enough resources to provide appropriate healthcare to living patients. Okay, so behind our thought of prevention, there is our thought of what do we do with those patients that are already alive. We need to have the resources to treat them. At that time, of course, the treatment was very basic. Blood transfusion and iron chelation to remove the iron, which the blood that we were transfusing the patient with was poisoning their bodies. As I said, in those days, 1971-72, we had about 500 patients and about 70 new cases each year. At that time, treatment was uncertain. We used to give them blood transfusions, but they were irregular. The pre-transfusion hemoglobin was very low. Finding blood donors was a problem. We didn't have voluntary blood donation in those days. Donors were recruited by a replacement system. In other words, the family went around their relatives, went around their friends, and had to find donors, and very often had to pay donors out of their own pocket in order to get blood for their children. You can imagine what a difficult life this was for the families. Iron chelation, which is the mainstay of treatment. In other words, if you don't remove the iron which is supplied by the blood transfusions, the body will be poisoned. The heart will be poisoned, the liver will be poisoned by the excess iron. Therefore, we offer iron chelation treatment. Now, in those days, there was only one drug available, not like today, which was desferrioxamine, otherwise known as Desferal, and this is a drug that needs to be given daily by infusion over 10 or 12 hours per day. In those days, our health service, instead of providing enough vials for a month, they provided only 12 vials per month. And this, of course, was totally inadequate. And if the doctor felt he should give more, the family had to buy it. Also, in those days, blood transfusions were given in a busy pediatric ward. And we had in the pediatric wards a mixture of older patients and younger patients interfering, if you like, with the smooth running of a pediatric ward. And this was the kind of picture that we had throughout the 1960s and the early 1970s. As you see, this child, because of thalassemia, because of the anemia and the resulting expansion of the bone marrow, as you see, this child is quite deformed. He has bone marrow developing in the bones of the skull, and he's got this bossing in the bones of the maxilla, so his cheeks are protruding. His face is quite deformed, and his arms and legs are also deformed. And I hope that you can see here there is a very big liver, and here a very big spleen. This is the characteristic of an undertreated thalassemia patient that we used to know in the past. So what do we need? In fact, we need lifelong adherence to a demanding and expensive treatment if we're going to achieve survival and a good quality of life. This ideal has been long realized, and our patients, as I will show you later, are actually now able to have this good quality long life. But in those days, the fact was fully understood that a few doctors and a few parents were aware that if they treat their patients better, then the patients would actually survive better. So we were already aware that we needed to increase our treatment. We needed to increase blood transfusion. We needed to increase iron chelation. So we made an estimate. What would happen in 30 years' time if we continue to increase? First of all, we should expect, in theory, an increased survival. Therefore, the patients who do not die would actually increase. As I said before, 1 in 1,000 of our population was affected. If they didn't die and they survived, 1 in about 100 would be the result in about 30 years. And the cost of treatment would rise, very much so. The number of blood vials that we would need to cover them would increase very, very much. And we make this sort of calculation of cost. So we estimated that in 30 years, more than 50% of the population would have to become blood donors. And of course, it is because of this prediction of increased needs in blood and drugs that we realized that we needed to have a prevention program. Nowadays, we have about 1,000 patients. Most of them have B-Thalassaemia major, which is blood transfusion dependent thalassemia. We have some 100 patients with Thalassaemia Intermedia, which is what we call non-transfusion dependent thalassemia, and hemoglobin H disease, which is an alpha thalassemia. In Cyprus, we have very few sickle cell patients. So that our prediction of the 1970s that we would have an increase of patients actually became true. We have had a significant increase, double the number of patients that we had in the 1970s. Therefore, we decided that we must have an effective prevention program. And what are the components of such a program? First, public education and awareness. You cannot ask people to take part in a program which involves interference, if you like, with marriage, interference with how many children people are expected to have, a couple that is at risk, unless the public is aware, unless the public is educated. So we started a public education and awareness campaign way back in the 1970s. How we did this, I'm going to come back to in a minute. The second component is genetic counseling. We needed to have counselors. We needed to have people who could explain to the public what thalassemia is, why we need to prevent it. And once we have recognized a couple that is really at risk, in other words, they're both carriers, we had to give them proper counseling to explain to them what to do. And then we needed a population screening campaign. And this required specialized labs. So we had to plan to have specialized laboratories. And of course, over the years, new technologies became available. Prenatal diagnosis, in which we diagnose the baby before it's born, early enough before it's born, so that if the baby is going to be affected, then the parents may have the choice to terminate that pregnancy. Pre-implantation diagnosis came very much later, and this technique allows, through in vitro fertilization, in other words, through collecting the eggs of the mother, to identify which eggs carry the abnormal gene and which do not. And this helps to fertilize only those eggs that do not carry the abnormal gene. So, in 1972 in Cyprus, we started, as I said, health education and population screening. The people that were found to be carriers when they were screened were actually counseled, but all we could offer at that time was to say, try and avoid marrying another carrier. That's all we could say, because there was no other solution we could offer. However, by 1977, in the United Kingdom, prenatal diagnosis became available. And we offered this to couples at risk in Cyprus. And we weren't able in the beginning to do this, but we were able to send couples to the UK, to London, and to Greece, and to Israel. In other words, centers where the technique was established so that our people could have the benefit, if they wished, of this technique. In 1978, we realized that ordinary hospital labs could not deal with the diagnostic difficulties of screening or of prenatal diagnosis. So in 1978, we established the first specialized laboratory which dealt with screening of the population and eventually with other techniques. And again, for the sake of patients and for the sake of a complete thalassemia program, we established a separate center. We called it the National Thalassemia Center, which contained both specialized laboratory and a daycare center for the patients that needed blood transfusion. This center is still functioning today, so many years later. Then prenatal diagnosis in 1983 was established in Cyprus. Now, prenatal diagnosis involves termination of pregnancy. And termination of pregnancy is opposed by religious bodies. And the Church of Cyprus, and I have to tell you that in those days, the majority of marriages took place in church. So the church objected to termination of pregnancy, and they wanted the people to come before marriage, before they committed themselves to each other. So we agreed to give the church a certificate that a couple had been tested without telling them, of course, without disclosing the actual result. So the fact that a premarital certificate was required actually meant that more people were able to come or were required to come for testing. And of course, after the 1990s, molecular methods made our life easier and new technologies were able to be established. So let's talk about the clinical management again, because remember, at the back of our mind is what do we do with the patients that we have. Blood transfusion was the basic treatment, and then eventually iron chelation became basic. And in 1974, the first support groups, the blood support, the Thalassaemia Anti-Anemia Society, as it was called, was formed to become a pressure group to advocate with government and parliament for improved treatment of patients, improved prevention of cases. So political, if you like, pressure from the community came very early in our program. In 1976, we gave much more attention to voluntary blood donation. We realized that parents could not be asked to beg for blood. And we developed a committee that took over blood donation, educating the public on the safety of blood and increasing voluntary blood donation very successfully. As I said before, in 1982 we opened the center, and we continued improving clinical management and offering patients better support. By 1996, the Cyprus family group, this patient parents anti-anemia group, joined with other patient support groups in other countries. In India, in the United States, in the United Kingdom, in Greece and in Italy, and they formed the international association that you now know of as TIF, the Thalassaemia International Federation. It was formed in 1996. Now, effective patient care, it's not just getting treatment provided. First, you need to have a register of patients. You need to know how many patients you have. Where do these patients live? If you don't, how can you persuade government to provide such services? We need to have epidemiological, if you like, knowledge of thalassemia. We need also to provide free medical treatment. No family, however rich, however prosperous, can actually provide daily treatment and daily monitoring with expensive tests in order to provide such treatment. And what was achieved in the mid-1970s, especially by the Parents Association, was free medical treatment. And of course, the expert reference centers that were able to provide good quality of care using good standards of care. Again, as I said, we gave a lot of emphasis to voluntary blood donation and good psychosocial support. Quality healthcare needs to be accessible and free of charge for all patients, wherever they might be. Therefore, let me go back to those factors that contributed to the control of thalassemia in Cyprus. As I said, first, we started with health education, our awareness campaign. For this, we needed the active participation of government, Ministry of Health, Ministry of Finance, because we needed a budget for all this, and the Ministry of Education, because we needed to start educating high school students on basic Mendelian law, on how these diseases are inherited. We also needed to educate health professionals. In medical schools of those days, thalassemia and sickle cell disease was small print. Very few health professionals knew about them. And this is the situation in some parts of India today. Health professionals don't know. We needed to raise awareness with the Orthodox Church and with other religious bodies because they had a role to play in influencing people, especially with regards to screening. We needed to educate patients and parents, and that's how they formed the support groups. We used, of course, mass media to inform the public, but our experience was that teaching students at school was actually the most effective way of educating, and students that were taught in school never forgot the basic premises of inherited disease and of thalassemia. We had to focus on reaching everyone, the general public, the health professionals, especially pediatricians and gynecologists who were asked to, the gynecologists were asked to deal with pregnant ladies and prenatal diagnosis later. We needed to influence policymakers. Policymakers do not always know rare conditions, do not always recognize the significance of hereditary disease. They often think they have other priorities. The students, of course, and of course patients and the parents had to be educated also. And then we started population screening. Now, the aim was to establish voluntary, premarital, and preconceptual, in other words, before any pregnancy. So our screening program was planned to do this, with the exception that the church was encouraging premarital screening. So we needed a policy. What time is the best to screen? Should we screen in childhood? Should we screen pregnant women? Should we screen premarital couples that are ready to get married? Whom do we screen? Who do we screen? So these are policy decisions which helps us to target the population to be screened. One possible target could be the families of patients, or the families of somebody that we already know is a carrier, especially in communities where consanguineous marriage, cousin marriage, is customary. So all these things have to be decided upon. Who does the screening? As you see, we in Cyprus decided to have specialized labs. We had specialized labs because screening is not always easy. There are difficulties, diagnostic difficulties. Who is a real carrier? Who is not a real carrier? There are diagnostic difficulties, and that's why we need specialization. And when to screen, of course, as I said before marriage, after marriage, during pregnancy, when women attend the antenatal clinic, wait after the birth of an affected child, which is secondary prevention, of course, or doing extended family screening. Having screened, what do we need to do? We need to provide counseling, especially to at-risk individuals, but most of all to at-risk couples. In other words, couples who are both carriers. And we needed specialists to deliver this information. Not everybody can actually give a full and transparent information. What is thalassemia? What are its consequences? Why should it be prevented? How do we explain the hereditary? How do we explain the chance of 1 in 4 children in each pregnancy could possibly be affected? How do we give this information without causing confusion? So, and also, we need to accept that confidentiality is necessary. We need to respect the autonomy of the couple. They have to make their choices concerning any prevention, concerning any diagnosis, and concerning any treatment. So, the principles are that our counselors should be able to give full information, but at the same time not to direct the couple to particular solutions, let them choose the solutions, and make everything equal access to all. Now in Cyprus, we, the doctors of the center, actually undertook this, supported by the laboratory scientists who are doing the screening. And of course, again, I repeat, the aim was to reach everybody, to be understood and recognized by everyone, which equals equity of access to all aspects of the program. Now, again, in order to understand all this, we had to understand how our population reacts. And this is something that any community that embarks on genetic prevention should be able to do. Now, for example, in the early 80s, when people were still rather ignorant, when we asked them, would you stop marrying if you know that your partner was a carrier? 10% said yes. But when knowledge came about, they preferred to stay together. Over the years, not more than 3% of couples in Cyprus actually separate because of their genetic risk. Would it stop them having children? When knowledge was theoretical, 20% said yes, we won't have any children. But by the late 1990s, when prenatal diagnosis became available and other methods, they attempted to have children. Would they undergo prenatal diagnosis? Of course, most of them said yes from the beginning. Would you proceed with pregnancy without prenatal diagnosis? 10% said yes, but hardly anybody said yes when they had full knowledge. What about termination? Termination was accepted from the beginning. Or termination of an affected pregnancy was accepted from the beginning by the vast majority of people. Certainly they didn't want to have a child that sick. Very few people actually said that they would have a sick child. And you will see how the introduction of each new factor affected. For example, when we introduced genetic counseling, and as the only response to finding carriers, you will see that we had only partial success in our prevention program. When we introduced prenatal diagnosis and we had to send couples abroad, there was a dramatic increase in the the prevention program. So most people were actually risking their pregnancy, were actually preferring to travel abroad in order to avoid having a thalassaemic child. When we, of course, developed prenatal diagnosis in Cyprus, again, this made it even more accessible to people. And of course, once most people came before marriage and had full choice, our prevention program became 100% successful. Couples at risk varied from, that we detected varied from year to year according to the marriage rate. But note something that's changing. The number of couples at risk that we detect each year is going down. And one of the reasons is that church marriages are actually getting less in Cyprus. More people are living together without getting married. A lot of people get married in civil weddings where the marriage certificate requested by the church is not necessary. And this is a cultural change in this population. And anyone wanting to start a prevention program should understand the cultural climate in which this prevention program is being offered and understand the cultural changes that might take place over time. For example, one question in India is, are there unregistered marriages? How do we find those people to screen them? And again, this slide is to give you an idea of how important genetic counseling and proper information is. In the early days, in 1978-1980, you will see that the residual births, the number of children born, most of them were born because the parents were misinformed, and some of them, in other words, they went to somebody who explained their risk in a very wrong manner, and they were misinformed. And some weren't even informed at all. And of course, laboratory errors were occurring. Therefore, children were being born because of deficiencies in the system. And then if you go some years later, and in this 10-year period, from 85 to 94, only 15 cases were born. So already our situation was getting better. And you will see that most cases being born now in this period were because of parental decision or because the child was illegitimate and it was missed, the mother was missed in the screening. Laboratory errors, of course, still possibly occurred at that time. Therefore, let me summarize. What were the factors that made Cyprus a success? First of all, political commitment. This means that we had the support of government, and this also means that we had a budget in which to work. The involvement of the religious people, the church, that encouraged people to come before marriage to be tested was actually positive. It did not mean that people separated. Perhaps that's what the church expected if they were carriers, but it did mean that most people actually were screened. Our population in Cyprus, of course, is small and homogeneous. It has a high literacy rate. This is in contrast again to some other populations where the population is more complex, more heterogeneous, and culturally different. The fact that we engaged the public, the medical community, and especially the parents and the patients themselves in our program from the beginning was a big factor of success. Strong national support associations were formed. And our Anti-Anemia Association played a big political role in helping us to establish. Of course, Cyprus had by this time and was developing a good health infrastructure, good health services, which enabled this kind of program. And of course, we did not neglect international help. WHO was involved with us from the beginning, and we helped, and we asked, and had contact and still have contact with international experts in thalassemia, so that we keep up to date. In this graph, you see these are the expected births, which we can calculate by a special calculation based on the number of carriers that we have in our population, based on the number of births, based on the birth rate. We can calculate how many patients do we expect to be born each year. The fall that you see here in the expected births is due to the falling birth rate over the years in Cyprus. However, the green line are the actual births. And you see that by the late 1980s, we had already touched almost zero. We still get babies being born, but they are very small in amount. We have achieved over 90% prevention. And this has saved resources for our children. This is really what we were also aiming for. We were aiming to improve patient care. In 1973, despite the fact that little was known about proper treatment, we tried to keep a common patient protocol throughout Cyprus in all our centers. We looked after, as I said before, blood donation, and we raised awareness. We achieved by 1978 free treatment and prevention for hemoglobin disorders from the Council of Ministers, and this holds to this day. To this day, all our patients receive all treatment modalities absolutely free, and all prevention is provided absolutely free. This is why we were able to sustain this program through the years. We have, of course, a separate thalassemia center, as I said before, so that the daycare of patients is more comfortable. They have outpatient services, they have privacy for their blood transfusion, and they are totally separate from the sick people that enter the various wards of hematology, etc. Over the years, because as they grow, thalassemics have complications, we offer them now multidisciplinary care. We have now all 3 alkylators available to us. We have monitoring technology like MRI. Therefore, we are able to provide optimum care for our patients. And this is one of the basic reasons why we have a prevention program. Now, look at these age distribution curves. Here you see Cyprus in 1999, and you will see that the number of new cases, this is the age of patients. The younger age groups, very few patients we had, and this is the product of prevention. Good treatment meant that our patients were now adults. In fact, if you were to look at a newer curve, you'll see that our patients are now, this peak is now at the age of about 40, 45. It's up here. What happens in a country that does not have any prevention or a proper patient care program? First, you will see that all their patients are young. They reach up to the age of 8 or 10. And then by the age of 16, 15, 16, most of them are dead, and very few survive. This is the contrast of the country with no program and the country with a program that involves both prevention and patient care. And over the years, we have been tackling problems. The red group here, the red columns, are the deaths that were caused by iron deposition to the heart. And you will see that until 1999, this was the major cause of death. Over the years, we have been able to reduce, and now it's even much lower, we have been able to reduce cardiac deaths. Why? Because we found the reason for this death, for these deaths, which were the effect of iron on the heart. We started measuring iron in the heart through MRI, and we are able to capture the patient early when the heart is beginning to get affected by the iron. We were actually able to remove the iron in time to prevent. And again, this is another demonstration. This is a Hardy-Weinberg rule. This is a Kaplan-Meier curve showing that patients in green, this green line, these are patients that were born in the 1960s, and you will see that their numbers are reduced by the age of 35. Okay? By the age of 35, 40, their numbers are reduced. Why? Because these patients did not benefit from optimum treatment. Iron got to the heart and to the liver much earlier, and we were not able to save them. And then patients in purple, born in the late 1970s, have a better outcome, and yet patients born in the 1980s are all still alive. So as treatment improves, so does patient survival improve. How could we have done this? How could we have saved so many patients if we had not a prevention program? This is just to show you the quality of life of our patients. These are blood transfusion dependent patients. And in the Nicosia clinic, those over 18 were 239 patients. Over half, 56%, are actually married. A few of them actually managed to get married and get divorced. 82% of them have become parents. And of course some are non-fertile. And we had, this is an older slide, it's about 2 or 3 years old, but we have about 200 children born to parents who suffer from thalassemia themselves. So, this is a thalassemia patient. He died about the age of 60 and led a very good life. Thank you for listening, and I hope that I make clear some of your questions through some of your queries through your questions. Thank you very much.
The questions are already shared with you, Dr. Michael.
Where can I find them? So
let me read the question for you. Let me read the questions for you.
Yes, okay.
So the question is from Suraj Ravindran, and the question is, like oncology accounts for a huge portion of clinical trials in phase 3. What percentage would account for thalassemia?
Well, at the moment, of course, thalassemia is in a changing period. There are new treatments, and there are clinical trials in phase 3 for thalassemia also. For example, there are new drugs available which will certainly reduce the number of blood transfusions, and even in non-transfusion dependent thalassemia actually stop blood transfusions altogether. Also, there are phase 3 trials or phase 2 trials anyway in gene therapy, which we hope will be the final cure of thalassemia. So, activity in red cell disorders is less, of course, than for other malignant conditions. But we do have clinical trials in phase 3, and within a year or two, we hope to have new drugs available.
Next question is from Dr. Rashmi, and the question is, how effective is gene therapy in treating thalassemia?
Well, okay, gene therapy, of course, is still under trial, but from what we have seen in at least one trial that has been published, and that's the Bluebird trial, we do have very good success. We have one original patient who has now been transfusion independent for several years, and we have for shorter amounts of time several patients now who are free of blood transfusion and who we can say are not thalassemic anymore. So gene therapy is in fact increasing. It is in fact effective, yes. Of course, a lot of these patients have to be followed long term, before we can actually be sure that there are no long-term side effects.
Next question is from Abhishek Srivastav, and he wants to know what would be the complications in case of bone marrow transplant for treatment.
Okay, bone marrow transplantation is a technique which has released, if you like, complications if the affected child is young, before iron poisoning of the liver, especially before iron overload. Therefore, the child should be, if possible, under the age of 10, or at least under the age of about 15, have been well chelated in the past so that there is not much iron overload there. And if that patient has a sibling, in other words, a brother and sister from the same family who are HLA compatible, in other words, they have the same HLA makeup. Now, only about 25% maximum of patients have this luck to have a brother or a sister who are compatible and who are being transplanted earlier. As people try to have a transplant later in life, or if people try to find a compatible donor which is not related, or even what we call a haploidentical donor, a mother, for example, or a father from one of their parents. Basically, then complications will increase, and even death may happen because of the transplant. Death may happen because In order to transplant, you need to kill all the bone marrow of the patient, making him vulnerable to infections. Therefore, one has to have the transplant in specialized units. So the conditions in which the transplant is done are very important. The other complications like graft versus host reaction, GVHD, also increase. They increase with age and they increase with the type of donor. And of course, again, an experienced and specialized center is required to do this. Therefore, if we're going to develop a policy of transplanting patients, it is best that we choose children, well-treated children, properly chelated from the beginning, who don't have iron overload, and who have a brother and sister who are HLA compatible.
The next question is from Prabhat, and the question is, what would be your top strategies to prevent the new thalassemia birth in India for Government of India?
You're talking about deaths from thalassemia. Am I right? Because deaths from thalassemia will of course occur in infancy if the child is left untreated. Therefore, the point number one would be the need for early diagnosis. And we must do this. We must try to identify patients as soon after their birth. One technique is to do neonatal screening. Now, neonatal screening, in other words, screening from cord blood or from a heel prick a few days after the baby is born. Now, that technique is excellent for sickle cell disease and other variants like hemoglobin D, hemoglobin E, but is not so effective for thalassemia. However, it is one way, and especially in areas where, in areas of India, where sickle cell disease and these variants, these important variants occur, like Middle India, like the eastern provinces of India, then I would certainly recommend a neonatal screening policy. This will also pick up some of the thalassemia major patients. The trick, however, is early diagnosis. We need to sensitize pediatricians. We need to sensitize general practitioners. When they see a pale patient, a patient with a big spleen, a biggish liver, bone changes, to make sure they refer them to a specialized unit, a thalassemia unit. Now, early treatment, early iron chelation, especially iron chelation as early as possible, will keep the poison down. It will not allow the iron to poison the patient. So, I think these are the two principles. Neonatal screening where possible, this is a good policy, and early treatment and early chelation.
So the next question is from Dr. Chetan Prasad, and he wants to know what kind of social interventions are optimal in tribal region of India to prevent thalassemia.
Okay, this is not an easy question. Tribal groups have their own culture. They often have their own language. And approaching such groups is a puzzle for everybody. Basically, you need to have educated professionals who know the language, who actually know the culture and have a feeling of the culture of these groups. And they should approach the groups, talk to them, go to their villages, arrange with the headman or whoever to have the village collected, speak to them in their language, explain to them about sickle cell disease, about thalassemia, about these hereditary diseases. Speak to them about how screening can diagnose the person who is likely to have a sick child. Understand what their marriage pattern is like. Do they have cousin marriage? Are they free to marry whoever they want? What are the family relationships? All these things can only be done by knowing the community, knowing its culture, knowing what they would accept. For example, is stigmatization going to prevent or going to isolate carriers in such communities? These are questions that can only be answered for each community separately and by experts who know the community and possibly be derived from that community themselves. So awareness is, I believe, the major issue here. Awareness and education.
Next question is from Dr. Keshav, and the question is, how has been the impact of your success in your neighboring countries?
Well, of course, Cyprus was not the only country to succeed. The countries of the Mediterranean basin, like Greece and Italy, also started early. Cyprus was easier because it's smaller, but these countries have also succeeded. Now the message has spread to many countries. Turkey has a very good prevention program. Some of the Arab nations have a good prevention program and a good control program. I should mention Lebanon. I should mention Jordan. Saudi Arabia is progressing. So other countries have actually followed what Cyprus has done and what Italy has done and what Greece has done in the beginning. There is a very good program in the United Kingdom and in France where these conditions were imported by immigrants. Cypriots, Greeks, Italians, Pakistanis and Indians, especially in the United Kingdom. And a good program has actually been involved. So Cyprus may be a model. Its success is partly due to its small size, but it's a model. And we hope that India will actually follow such a model, develop its own program.
Next question is from Dr. Sanjeev, and question is, tell us something about the latest breakthrough in thalassemia treatment.
The latest breakthrough. I think, as I said in answer to the first question, there are new drugs which take advantage of the various steps that occur in erythropoiesis. And these drugs are now going to phase 3 trials. What do? They help to stop erythropoiesis at a time when there are enzymes that can take out the excess alpha chains, which in B-Thalassaemia do the damage to the red cell, to the young red cells. And one such drug, Thalassaemia it's called, is in fact already starting in a few centers, both in Europe and the USA, is already starting now a phase 3 trial. Phase 2 trials have shown that these drugs in the short term are both effective and safe. In the short term, they increase the rate of the hemoglobin. In non-transfusion dependent thalassemia, they increase the hemoglobin to a level where blood transfusion is no longer necessary, and in transfusion-dependent thalassemia, they most certainly widen the interval between blood transfusions. So this is the most exciting development at the moment. The trials on gene therapy are also successful at the moment, again, but we're talking about early phases. We don't have long-term data, but we know that many patients are already transfusion-free that have been treated by gene therapy. So in gene therapy, what we're waiting for is to see long-term long-term effects of this treatment. There are other drugs in the pipeline. Again, drugs which influence the excess alpha chains, drugs which redress the balance between the various chains that make up the hemoglobin molecule. But these have not yet progressed so far into phase 3 trials. The only drug that I know that is in phase 3 trials is luspatercept. And we hope, as I said, that in a year or two we will have good results.
Thank you, Dr. Michael, for taking this webinar session on conquering thalassemia. It was really an engaging and insightful talk, and we hope all the participants enjoyed the session. You can send us your questions at editor@ETHealthworld.com, as we won't be able to take all the questions due to time constraints. The recording of this webinar will be made available on ETHealthworld.com by tomorrow. Thank you everyone for joining this webinar. Signing off.
Thank you very much indeed. Bye-bye.